Hello, everyone. Good afternoon. So today is the final session from my side. This is on antimicrobial stewardship, and I'll be focusing on areas of kinetics and dynamics of antibiotics. How do we risk stratify our patients who are at risk of multi-drug resistant pathogens, and de-escalation. Along with that, I'll try to kind of weave of a story about antibiotics. So I'll request you to just be with me. I know it's difficult on an online session, but rather than trying to learn too many things, let's take this session as a story of antibiotics and how different bugs act and how we can win this battle against them. Okay. I have certain question and answers inbuilt. We will also do a small quiz in order to make it interactive. Okay, so this is very interesting. I don't know how many of you have read Yuval Harari's Homo Sapiens and Homo Deus, one of the two most amazing novels, part fiction, part reality, part history. So in that book, in Homo Deus, the second part says, famine, epidemics, and war. They have been the three biggest killers of humanity since time immemorial. And if you look at epidemics, every 200 years in the history, in the last thousands years, there has been an epidemic. In 14th century, plague killed about 220 million people in Eurasia. Then in the 16th century, it's a smallpox. In the 18th century, it was again flu and TB. And then almost 100 years ago, there was Spanish flu. And now we are again handling the COVID. So the idea was that these microorganisms have been killing people on a regular basis. And see what impact antibiotics have made on the history, on the mortality. Just look at endocarditis and brain infection. Just before antibiotics, these were almost a death sentence with more than 80% mortality. And now antibiotics have led to about 60 to 70% reduction in overall mortality. Okay. Now compare that with the role of aspirin and streptokinase. They have reduced the mortality in myocardial infection by only 3%. And still we think aspirin, streptokinase are such life-changing therapies. But if you look at antibiotics, they are the real lifesavers. If you know, even in US, before antibiotics, the average life expectancy was 40 years, and now after antibiotics, so antibiotics have played a major role in improving the life expectancy now in developed countries to almost 84, 85. I live in Singapore. The life expectancy here is 82 to 84. Even in India now, it is more than 70. So antibiotics have played a very important role in letting us humans live longer. Okay. But it's just a very small success story. The first antibiotic was used in the Second World War in 1941-42, when penicillin was used for the first time. And then the next 2 years, 40s to 60s, 2 decades, this was the age of golden age of revolution. Okay. By 80s, we already had started getting reports of MRSA and ESBLs. Then came the age of neglect from 80s to 2000. That's where the antibiotic resistance started catching up. The pharmaceutical industry started focusing more on drugs for depression, for hypertension, for cardiovascular, for diabetes, and acute care drugs like antibiotics was neglected. And in the last 20 years, now we have realized this, that if we do not take any actions, then by 2040, exactly 100 years after the antibiotics were discovered, we might enter a post-antibiotic era. So antibiotics have been a superstar, but with a very short lifespan. Okay, and there was a survey conducted by WHO in the last century that the biggest medical discovery in the last century, number 1 was X-rays, and number 2 was antibiotics. Okay, so we are really talking about a class of drugs which is very precious. I always say we have to pass 4 things to the next generation: clean air, clean water, fuel, and antibiotics. And all 4 are in danger. Okay, so that's why it's so important to save this very precious class of drugs. And what you are going to learn is really going to help in prolonging the life of these very valuable drugs. Okay, what is antibiotic resistance? You all know, and I know Dr. Jyotsna and other microbiologists and there will talk about resistance. So this was 2017 WHO report. So they talked about critical, high priority and medium priority pathogens. These are those bugs for which we need urgent antibiotics. And the top priority, the critical priority is 3 bugs: crab, CRPA, CRE. What is crab? Carbapenem resistant Acinetobacter baumannii, carbapenem resistant Pseudomonas aeruginosa, and carbapenem resistant Enterobacteriaceae. And even if you look at your ICUs, these are the 3 biggest killers, 3 biggest resistance headaches that we have with us today. I am really a big fan of this paper. You know, this paper was published way back in 2014 by Jim O'Neill, who was an economist with Goldman Sachs Bank. He was asked by the then British Prime Minister, David Cameron, to do a review on antibiotic resistance. And I can tell you, I have been in this business now for 14 years. Before this paper came, the world did not take antibiotic resistance seriously. They thought it's a third world country problem. It's a problem of China, Asia, Southeast Asia. But after this paper came, it actually quantified the impact of resistance on humanity and on economics, and money talks. So what this paper said, that by the year 2050, if we do not take any action on AMR, 10 million people might die annually of AMR, which will be higher than cancer and diabetes put together. And they also said that this will lead to a loss of 100 trillion US dollars, and 2 to 3% of the world GDP will go down. And after this paper came up, I know how the world kind of started talking about it. In the last 4 years, even in the UN General Assembly, there is a topic on antimicrobial resistance. Okay, so I really recommend all of you. There were 4 papers published by Jim O'Neill: problem statement, causes of problem, and then also on the solutions. Okay, India is the hotbed of AMR, and what I'm going to show you the data. It was just published last month in January in Lancet. So what is this data? Look at MRSA. Now we think India is a gram negative problem. We don't have much gram positives, but even our MRSA rates are 50 to 60%. You know, हमें ये ज़्यादा इसलिए नहीं लगता because our ESBLs and gram negative is more than 80%. But that does not mean that we do not have gram positive issue. So see, India, China, Southeast Asia, even MRSA rates are 50 to 60%. Okay. What about ESBL? Here we are undeclared world champions. Our ESBL rates is more than 80%, which means what is an ESBL? An enzyme produced by E. coli or Klebsiella, which makes all penicillins, all cephalosporins, and even monobactams resistant. Drug of choice is carbapenem. Can you imagine tomorrow's situation? Your most common community-acquired pathogen is E. coli. And one of the most common community-acquired infections is urinary tract infection. If tomorrow a 26-year-old newly married female comes to you with a lower urinary tract infection, which has E. coli, which is a carbapenem producer or an ESBL producer, you just have to give the highest spectrum drugs for this very simple infection. So we are staring at that kind of a situation. Okay. What about CRE? Again, one of the biggest issues, carbapenem resistant Enterobacteriaceae, and mainly we are talking about Klebsiella here. And again, see, unfortunately, our rates are already 50 to 60%. US, Europe, their rates are 5 to 10%, and they are already shaken that how come CRE rates are 10% and our rates are 50 to 60% as per this latest Lancet report. And of course, one of the biggest killers in ICU, carbapenem resistant Acinetobacter baumannii. Across the globe, the resistance rates are more than 50%, usually in barring Canada, Australia. But other countries, look at Russia, look at India, again, more than 80% crab incidence. Okay, so we are really talking about some very sinister bugs, mainly crab, CRPA, CRE, ESBLs, and unfortunately, India is a powerhouse for all of them. Okay. Now, we can all say that, so what? Ignorance is not a bliss when it comes to your local antibiogram. And I'm showing you this one data chart. This was shown to me way back in 2012. I visited one of the public hospitals in Delhi for a similar lecture. And I asked them, what is your ESBL rate? So one of the surgeons stood up from the audience and said, Dr. Ankur, we don't have ESBLs in our hospital. And I was like amazed that that's quite a statement. I said, sir, why do you say you don't have ESBLs? He says, our microbiologist never tells us whether this is an ESBL or not. So I told, sir, absence of evidence is not evidence of absence. Okay. It does not mean that if you are not told about your data, you don't have ESBLs. This is, ostrich in the sand syndrome. So I asked them, I asked the microbiologist, can you show me some data, whatever data you have? So they showed me this one graph. And can you imagine what was happening in this hospital? This is ceftriaxone. And look at resistance of E. coli and Klebsiella to ceftriaxone. 89% E. coli Klebsiella were resistant to ceftriaxone in this hospital, which is an indirect surrogate marker of ESBL. So you are sitting on a volcano, on a mountain of ESBLs, on a resistance without knowing it. So definitely ignorance is not a piece. And I'll focus more on this. Please ask your microbiologist, ask your pharmacologist to share the local antibiograms with you. And if you have doubts over data, remember this, some data is better than no data. Please trust your microbiologist, trust your data. Okay. No data is sacrosanct. I know there will be some background noise, there will be some junk there, but at least you will have some idea of what is happening in your hospital. Okay. And why in India, this is what I call this is antibiotic anarchy in India, especially. Our hospitals are not conducive for treatment protocols on antibiotics. We have very few infectious disease physicians. Our pharmaceutical industry have their own role to play in and adding to resistance. We have more than 150 meropenams, piptazos, and companies are selling it for $250 to $2,500. It pains my heart to see when I see prescriptions by GPs in India writing meropenem 500 mg BD for typhoid fever. Okay. So this is absolute irrational, indiscriminate promotion by companies and also by some of the doctors. And that is the reason our resistance rates are so high. So in India, in France in 90s, there was a program called Antibiotic is Not Automatic. They ran a community program, education program for the general public that look, antibiotics are not automatic. Just common cold, sneeze, cough, you don't need to give antibiotics. And within 10 years, just because of this simple communication, their overall antibiotic consumption rates came down. But in India, unfortunately, I would still say antibiotics are automatic. If you look at 8 out of 10 discharge summaries, they will have an antacid, a multivitamin, a painkiller, and an antibiotic in the discharge summary. Okay. So I think this situation got to change. Okay. Now it's very important to know some of the common myths. What drives overuse of antibiotics? So let's learn about some myths about antibiotic use and what is the truth. First, all post-operative fevers require antibiotics. That's not true. Not all post-operative fevers are due to infection. Not all infections are due to bacteria. First 48 hours, it could be physiological. So do not escalate, do not overreact. And remember 4 W's. It could be wind, water, wound, and what did we do wrong? Could be iatrogenic, could be drug fever, could be a surgical site wound, could be urinary tract, could be any other. So post-surgery fevers, the only answer, as they say, ceftriaxone, fever is not a sign of ceftriaxone deficiency, right? So always think what could be the reason of this post-operative fever. Another common myth, IV antibiotics are more efficacious than oral. There is no truth to that. Frequently, we use IV antibiotics which are unnecessary. Okay, it prolongs in hospital stays, adds to the hospital cost, more monitoring, more chances of needle infections, more chances of iatrogenic hospital-acquired infections. Okay, and now we know the sooner you put the patient back on oral therapy, better it is. Okay, and this whole ERAS, enhanced recovery after surgery, one of the things is shifting from IV to oral as soon as possible. Okay. IV achieves rapid peak levels. You need that in severe sepsis, in bacterial meningitis. Okay, or if the patient's oral absorption is compromised, you need parenteral. That's the only way, right? But if you think that they will act faster or something, with same serum concentrations, IV antibiotics will work in 7 days and oral takes a week. Okay, so you can imagine. Okay, so IV antibiotics is not always the answer. The moment the patient is out of sepsis, can take orally, try to shift to oral antibiotics. And see this paper, do the bugs know or even care whether we are giving them oral or IV? Okay, so we have to rethink on that. Another common myth is more the merrier. Okay, if 2 are not working, add third. 3 are not working, add fourth. Okay, multiple antibiotics for simplest of infections. Shotgun approach, 1 is good, 2 or 3 can be better. A single antibiotic can be as effective against a single organism. This is what we have to remember. If it's a simple MRSA, only vancomycin is good enough. If it's an MSSA, MP amoxi is good enough. Single pathogen, single antibiotic is good enough if it's a sensitive pathogen. Okay, a single wide spectrum antibiotic may be used in many mixed infections also. Okay, there is no rationale in starting 2 antibiotics which show sensitivity. Okay, and I will talk about later when to combine 2 antibiotics. And even when you combine 2, never combine 2 antibiotics from the same class or same mechanism of action. Have different mechanism of action. Adding metrogyl to piptazo carbapenems is futile. Carbapenems, piptazo, I discussed this yesterday. They have good anaerobic coverage. Why add metrogyl to that? MP metrogenta as a prophylaxis is pass. As I told yesterday, only S for skin, S for Staph aureus. And if you're entering gut, E. coli. These are the only 2 bugs you have to cover for giving surgical prophylaxis. If you are giving piptazo for surgical prophylaxis, maybe it's an insurance policy if something can go wrong in the surgery. That's not antibiotic prophylaxis. I will call it a treatment already. Okay. Antifungals have well-defined indications, so there is no indication to give fluconazole to every surgical patient. There are very clear-cut guidelines now when to add antifungal. Okay. Another common misconception is that if we give combination therapy, they will have synergistic action and maybe better bacterial killing, faster onset of action, and faster recovery. That's not true in all the cases. Look at this. This is a review from meta-analysis, does not support the use of antimicrobial therapy usually. Okay, there are cases, for example, if it's a carbapenem resistant Acinetobacter baumannii, you have to give 2 or 3 drugs. Or carbapenem resistant Pseudomonas in a sepsis patient, maybe 2 drugs is better than 1. But generally for MRSA, for ESBLs, single drug is good enough. Another important thing or the rationale sometimes people give is, Dr. Ankur, you don't know, India is different. So we have to give more antibiotics. Our patients are weaker, our surroundings are dirtier, antibiotic policies are for healthier whites. We need to use higher antibiotics in all cases. Limiting surgical prophylaxis for just 24 hours is not for us. Okay, and discharge medication is incomplete without a 5 to 7 day course of antibiotics. These are all reasons that we give ourselves. See, I took a picture of one surgical department prescription. The patient is on meropenem, Lactagard, tigecycline, teicoplanin, xenocin. Okay. Now, what is the rationale for this? He is getting 5 antibiotics, 4 of which are not needed. Now, no amount of India is different story can justify this use of antibiotics. Okay. Yes, I know India is different, but the basic principles of microbiology remain the same. Use your local data. Ask the microbiologist for your ward or ICU antibiogram. And I will talk later in my talk how to make antibiograms. According to me, this is a very simple way of knowing your antibiogram. Which are the 5 most common pathogens for a particular infection? HAP, VAP, or UTI, or II, right? Most common pathogens, most sensitive antibiotics for every pathogen whose sensitivity is more than 60-70%. This antibiogram, this bug-drug combination should be available for everyone in ICU. Okay. Antibiotics can take care of pre and post-op goof-ups. I'm sorry, they are not an insurance policy. They will not prevent complications. They won't make up for lack of basic surgical principles like sterilization techniques or antisepsis. And has the source been controlled? If you have a post-surgical leak or an abscess formation, any amount of antibiotic will not help, right? You have to contain the source first. Another misconception is, don't worry, we have too many antibiotics. And I've already told you we are not. We are looking down at an empty barrel. Okay. If one does not work, we'll get new class. I'm sorry, that is not an issue. Another thing is AMR is not my problem. My problem is my immediate patient. I'm sorry, if your immediate patient goes home colonized with a resistant bacteria, the same patient will come to you tomorrow with a hospital-acquired infection with a resistant bug. So AMR is definitely your problem. It's not an NGO problem. Okay. So what I'm trying to paint the picture so far is that whatever justification we may give ourselves, still we cannot put rational antibiotic use on a hold. Okay. Pardon me for painting a grim picture, but is there a light at the end of the tunnel? I still believe there is light at the end of the tunnel. And we have to remember some common principles of use. Use, choose, stop, switch. Some very common principles. Okay. Coming to use. Who needs antibiotics? Always ask this question. Is this prophylaxis? If it's truly prophylaxis, it should end in 24 hours. Maximum 3 doses. Is this an emergency situation? Severe sepsis? Yes. Is it the golden hour? Patient needs antibiotic. So always question yourself, does this patient need antibiotic? Second, has the source been controlled? How do we adjust the dose? Simply because creatinine has gone up from 0.7 to 0.9, we reduce the dose of antibiotic to half. I'm sorry, that's not the right way. And I will talk that in PKPD. First dose of antibiotic should always be the highest possible dose. I know in the first 48 hours, patient is in a hyperdynamic state of sepsis. If you reduce the dose, they are anyways peeing out the antibiotic. The levels will not reach. So it's very important to know the dosage adjustment and when to give and when not to give. Okay. And then we have to know which drugs are time dependent and which drugs are concentration dependent antibiotics. So just remember, and I will talk this in detail. What are concentration dependent antibiotics? Whose efficacy depends on how high their Cmax is. What is Cmax? Maximum concentration in the serum. Higher the Cmax above the MIC, better they are. Fluoroquinolones, aminoglycosides are concentration dependent antibiotics. Okay. What are time dependent antibiotics? All beta lactams, PCMC, penicillin, cephalosporin, monobactam, carbapenems. Their efficacy does not depend on how high they go above MIC, but how long you can keep their concentration above MIC. Okay. And I will talk this in detail later. Another important issue is timing of starting antibiotics. Please remember, for septic shock, severe sepsis, first hour is the golden hour. The moment you make a clinical diagnosis, this is severe sepsis, septic shock, start empirical therapy. Antibiotic prophylaxis within 1 hour before operation. I'm sure all of you know that giving one night before, that practice is long gone. Normally they say when you induce the patient, that's the time to give antibiotics. What, when, and how to give prophylaxis? 30 to 60 minutes before incision. That maintains the therapeutic level. If operation lasts longer than 4 hours, or if the blood loss is more than 2 liters, give the second dose. Try to give a narrow spectrum agent and discontinue prophylaxis within 24 hours post-op. Okay. Then comes choose. Find your source or the likely source. The choice of empirical therapy for a pneumonia or a UTI is going to be totally different. I know if you have a carbapenem or a fluoroquine, it will cover everything from head to toe, but that's not science. That's not evidence-based medicine. Always, even if it's a, you think it's a sepsis, always look at what could be the possible source. That will determine your choice of empirical therapy. Always consider spectrum. Okay, am I giving, if you are suspecting an MRSA, line infection, okay, why you have to give anaerobic drug also, drug for anti-pseudomonal also. So always consider spectrum. Don't kill mice with missiles. Will it work? Penetration. Aminoglycosides have very limited penetration even in the GI tract. Okay, so think before you are adding a drug, what is its penetration? And do you need to give monotherapy or a combination of drugs? And most common bugs, this I am showing in secondary peritonitis, most common, your cholecystitis with rupture or perforation, appendicitis with rupture, abscess, E. coli and anaerobes. If I have to cover these two, amoxiclav is good enough, or maximum cefuroxime, ceftriaxone plus metrogyl is good enough. Okay, these should be good enough for such kind of patients with these infections. So it's very important to know normally what are the most common pathogens in community-acquired infections. Based upon that will be your empirical therapy. Which route to use? Of course, patient is serious, you need to reach high therapeutic levels, give parenteral, but the moment the patient is stable and can take orally, shift to oral. And the problem in India is that sometimes we think that empirical therapy goes on for 10 to 14 days. Either we don't send appropriate cultures or we do not believe the culture report. It's very important, once you have the culture positive, that's a gold mine. Getting a culture positive in an ICU in a sick patient, now you know what is the enemy. If you have started the patient on a vancomycin and a carbapenem and something else, but the culture shows it's a simple Staph aureus or an MRSA, why give carbapenem? So I think, and I'm sure Dr. Jyotsna and others are taking how to send a blood culture sample or how to take samples as another session. That's very important. Now we have clear data from Indian doctors that higher the amount of blood you send, more is the yield in culture positivity. And I think that's the very important part of stewardship, that if we get a culture positive, how do we modify our therapy after that and avoid giving empirical therapy for days together. Okay, coming to de-escalation, which is switch, and I will talk more about it. You need your culture positive. Patient should be clinically stable on day 3 than day 1 and lots of guts. Okay, de-escalation is not for the faint-hearted. Okay, change from broad to narrow in that case. Reduce the number of antibiotics, reduce the duration of antibiotics. That's what is known as de-escalation. One caution: reducing the dose is not de-escalation. I have seen some doctors say, Dr. Ankur, I was giving meropenem 3 times a day. Now patient is doing well, so I have reduced it to twice a day. I'm sorry. Bacteria love low dose. Okay, that's a recipe for resistance. Reducing the dose, unless it's a hepatic or renally compromised patient, neither this is cost de-escalation nor this is a tangible de-escalation. Okay, and when to stop? For most infections, 4 to 5 to 7 days is good enough. Prophylaxis 24 hours is good enough. Clinical indicators are good guide, and prolonged treatment is usually futile and harmful. And then you will start thinking of fungal infections if you give antibiotics too long. Okay, so I have covered the basics of antibiotics, and before I go to 3 important topics of risk stratification, de-escalation, and PKPD in detail, I'll just pause here and see if there are any questions, comments before we go ahead.